Good afternoon to all. Today I'll be taking the topic from recent advances 26, that is papillary renal cell carcinoma, past, present and future. So papillary RCC constitutes 15% of the RCC and it is the second most common type. The most common type is clear cell RCC, then second most common is papillary, and then comes the chromophore type. So why papillary it is called? Because of the architectural classification, that is papillary architecture it has. Details will come to later. It is more common in males and it is seen in African Americans especially, and mostly they occur sporadically. There are also familial and hereditary versions of papillary RCC, and in such conditions, the carcinoma can be multifocal lesion as well as can be seen in bilateral kidney. So, one of the hereditary lesion is the hereditary papillary renal carcinoma syndrome. It is caused due to germline mutation of c-Met proto-oncogene at chromosome 7, and these people have 90% predilection or chances to develop papillary RCC. Multiple papillary RCC can also be seen associated with end-stage renal disease or chronic renal disease. And that setting, that is end-stage renal disease and chronic renal disease, is much more common than the hereditary papillary RCC syndrome. So when you get multiple RCC, that also papillary RCC, you should check whether there is no end-stage renal disease and chronic renal disease, and then you should check for c-Met mutation. Historically, papillary RCC was classified into two types, that is type 1 and type 2. So type 1 has comparatively simple morphology. They have multiple papillae that are covered by single layer of basophil appearing neoplastic cells. Basophilic means it's comparatively bluer than the type 2. You can see there is, and the cytoplasm is less, and then there is small nuclei also, and in the fibrovascular cores you can see foamy macrophages. Okay, and the here, and then in type 2 they are more aggressive kind of papillary RCC. They have complex architecture, that means it can be in between there can be solid sheeting and tubular along with the papillary appearance, and then they are covered, the papillary cores are covered by larger neoplastic cells which has abundant eosinophilic cytoplasm and enlarged hyperchromatic nuclei. So they have abundant eosinophilic cytoplasm compared to the type 1, and they also can have foamy histiocytes and macrophages inside the fibrovascular core. But later on, it was found that that classification, when for every WHO classification of every systems, now it is becoming molecular after the genetics and mutations were discovered. So there is rearrangement of the tumor cells. Previously, it was mainly based on histomorphology, like we know adenocarcinoma, squamous cell carcinoma, and then neuroendocrine and all, because of the appearance of the cells. Okay, so and we have certain IHCs to differentiate, but then now it has all gone to molecular level. That is, even if adeno has 3 4 mutations, you can divide it into 4 types with different mutations. So but the importance is that we can classify into all these mutations, especially when there is difference in the prognosis. Okay, so now everything is going molecular level. So we have seen that in type 1 and type 2 there are tumors also with having combined type 1 type 2 type of histomorphology, and many of the notorious papillary RCCs come in the type 2, and they have certain molecular alterations, so they are considered as a separate entity in the 2022 WHO classification, and they're not included under the papillary RCC part. So after all those divisions, now the classification has only 4 tumors. Okay, it's not type 1, type 2. Now papillary RCC has 4 types. That is papillary renal neoplasm with reverse polarity, which has recurrent KRAS mutation. And then there is biphasic hyalinizing psammomatous RCC, which has recurrent NF2 mutation, that is neurofibromatosis. And then there is Warthin-like papillary RCC, and then biphasic, that is two phases. You can see that is alveolar and or squamoid papillary RCC. So this is papillary renal neoplasm with reverse polarity. So why is reverse polarity? Is because the nucleus is usually seen ideally in center or near to the basement membrane. Here what has happened is that the nucleus is going to the opposite part of the basement membrane, that is near to this luminal side. You can see it is blue color. Okay, so this is called reverse polarity because the nucleus is located away from the basement membrane. Okay, so this is papillary renal carcinoma with reverse polarity. It has more recurrent KRAS mutation. Then we have biphasic hyalinizing psammomatous RCC. So in these pictures, you can see there are papillary architecture. They are suppressed by hyalinized stroma. Okay, very hyalinized stroma. That is by hyalinizing. And then they are lined by large epithelial cells with vesicular chromatin. And then they have abundant psammomatous calcification. So psammomatous, hyalinizing psammomatous renal cell carcinoma. And then you have Warthin-like papillary RCC. Warthin-like is because they look like the Warthin salivary gland tumor. Okay, so how is in Warthin salivary gland tumor there were like double layered cells, papillary uh, papillary cores are covered by double layer of cells, and then in the core you have abundant lymphocytic infiltration. So in the same way, papillary RCC also, in the neoplastic cells look like Warthin tumor, like the oncocytic cells, and then the core has abundant lymphocytic infiltration. The fourth type, that is biphasic squamoid alveolar renal cell carcinoma. In this there is biphasic population, that is there is papillary architecture also. You can see here papillae is forming. Okay, micropapillae like also. And then there is also squamoid nest surrounded by smaller uniform nuclear cells, which gives a glomeruloid appearance. Okay, glomeruli in kidneys, you know that there are a bunch of cells in between, then there is a clear urinary space, and then there is the outside cellular lining, okay, of the epithelial cells. So such way here also there is an alveolar or glomeruloid kind of structure, and then squamoid appearance, etc., along with the papillary architecture. So it is called biphasic squamoid alveolar renal cell carcinoma. So histomorphologically, uh, after all those classifications according to molecular aberrations, etc., papillary architectural pattern is neither sensitive nor specific to papillary RCC. So, and papillary architecture can be seen in many renal tumors, including molecularly defined RCC. Okay, so when all the papillary RCC to classify, when scientists and pathologists had done molecular tests, they found many such aberrations. So, and then they classified accordingly, like TFE3 rearranged RCC, TFEB rearranged or amplified RCC, ALK rearranged RCC, ELOC mutated RCC, fumarate hydratase deficient RCC, SMARCB1 deficient renal medullary carcinoma. So these all were previously under papillary RCC, but then they were classified according to the targeted therapy they require, the prognosis, the clinico pathological features. They all are different tumors, so that is why they were reclassified according to the molecular biology and the clinico pathological features. And then there is also tuberous sclerosis associated RCC, and even there is an entity that is clear cell papillary RCC with both the morphology, clear cell as well as papillary. So now these things make it complex, that just because you are seeing papillary architecture, you cannot call it papillary RCC. It should fall under the four categories which I said before: biphasic alveolar, or biphasic hyalinizing psammomatous, or reverse polarity, or Warthin-like. And in that also you have to prove that molecular alterations are there. Okay, then only you can call now papillary RCC, or else you should distinguish it from the other architectural molecularly defined RCC also. So when there is densely and closely packed papillae, that is when you call there is a solid pattern to the papillary architecture. Okay, so when such a solid pattern occurs, then there is again a DD that occurs for papillary RCC, that is metanephric adenoma. But metanephric adenoma, IHC wise, they will show WT1 positivity and CD57 positivity. Then there are other features which I also said while describing the papillary RCC entities, that is there can be foamy macro features, psammomatous calcification, and there can be also hemosiderin laden macrophages or hemosiderin deposition also. But these things are not specific for papillary RCC. They can be seen in other types of tumors also, like clear cell, chromophobe, etc. also can show these findings. So these are not specific. So not only according to the papillary architecture, you have to go for the clinico-pathological context and molecular aberrations, and then only you can definitely call it as papillary RCC. So once you know it is papillary RCC, so now it is recommended that clear cell RCC and papillary RCC should follow this WHO or ISUP grading system. It was firstly introduced by ISUP grading system and WHO adopted it. So grade 1, the tumor cell nucleoli is invisible, inconspicuous nucleoli, or it is very small and basophilic, and it can be seen only in 400x magnification. Okay, and then grade 2 is when the nucleoli is conspicuous at 400x magnification, that is 40 into 10, that means it is in high power magnification, but it is inconspicuous at low power, that is 100x magnification. When you go to high power, only the nucleoli is visible. In grade 1, even in high power, it is invisible nucleoli, okay, or it is very small and basophilic. And grade 3 nucleoli is eosinophilic and clearly visible even at low power magnification. And in grade 4, there is extreme nuclear pleomorphism and tumor giant cells, and there is presence of sarcomatoid or rhabdoid dedifferentiation, etc. in the papillary RCC or clear cell RCC, whichever you are grading. So immunohistochemistry wise, more than 90 percentage of papillary RCC show low molecular weight cytokeratin, and they show also CD10 positivity. And most of the type 1, which was previously type 1 papillary RCC, show keratin 7 positivity. And most of the tumors show amaker as well as vimentin positivity, and other IHCs which we use like GATA3 carbonic anhydrase 9, which are urothelial markers, are negative, and fumarate hydratase can also be negative unless it is FH deficient RCC and all. Okay. And then TFE3 immunohistochemistry can be also used because I said TFE3 mutated RCC also can show papillary features. So to differentiate the different molecularly altered RCC from the papillary RCC. So ideally papillary RCC you should call it mainly when I said the 4 classifications, the reverse polarity Warthin like biphasic alveolar squamoid or hyalinizing psammomatous type is there. All other have different molecular entity or they are separately said in the WHO. And then cytogenetics wise, there is no cytogenetics that is very sensitive or specific to papillary RCC. However, there are frequent chromosome alterations like chromosome 17 gain, which is more seen in type 1. Type 2, you can get chromosome 1p, 3p, 5q alterations or monosomy 2 or loss of 9p. Deletion or loss of heterozygosity of chromosome 3p is more specific of clear cell RCC. So why this is used is to differentiate the clear cell papillary RCC from the papillary RCC. So clear cell papillary RCC is considered under clear cell RCC only. So coming to the conclusion, papillary RCC has a more favorable behavior and the behavior and prognosis than other histological subtypes of RCC like clear cell, etc. It has a favorable behavior. However, unlike the before classification, now the genetic alterations and all are coming up. So they are so divided into different types. Now the prognosis is also different for different entities according to the molecular alterations. but overall it has a much more favorable behavior. So we come to the end of this presentation. So I take this opportunity to thank Oluwayomi Oediji, Seen R. Williamson, and Khalil I. Al Obedi for contributing this article to the Recent Advances 26. Thank you.